So it is well known that BTK inhibitors lead to a long-lasting lymphocytosis. That is because these drugs interfere with recirculation of CLL cells. So what we asked in our research is whether CLL cells somehow adapt to this situation, to this forced circulation in peripheral blood, especially related to cell survival. And we primarily focused on a PI3-AKT pathway because it has been shown before that PI3 kinase activation can rescue the absence of BCR receptor on mature B cells. And indeed, when we investigated the activity of phospho-AKT in CLL samples before and during ibrutinib therapy, about 70% of CLL cases actually upregulate phospho-AKT above pre-therapy levels, which is something that is at least partially counterintuitive. To understand this on molecular level, we performed RNA sequencing in CLL samples before and during ibrutinib therapy, and this showed some interesting features such as activation of Richter, which is an assembly protein for the mTORC2 complex that directly phosphorylates AKT, and this could potentially explain why patients have increased phosphorylated AKT. And they are clearly dependent on this phospho-AKT because when we treat CLL cells on ibrutinib with an AKT inhibitor, this leads to a massive apoptosis. So then we looked for the factor that might be responsible for Richter induction, and that seems to be a transcription factor called FoxO1. When we knock out FoxO1, we see that these clones lose Richter and they basically completely lose phospho-AKT. The clinical implication potentially might be the targeting of FoxO1, and there is actually a FoxO1 inhibitor available that we tested in CLL. And that inhibitor by itself is able to kill CLL cells, and this is also synergistic with the use of ibrutinib or idelalisib in vitro.